doing a postdoc actually here at OBC, and so she's very familiar with our calls. And she now works as a scientist at the University of Techna. Her focus is mostly in musculoskeletal research. And today she's going to be speaking with us about osteolytic and osteoblastic and mixed bone metastases in a rat model, and talking about some of the effects of cancer in this tumors on bone.
Thank you very much for the introduction, Michelle. So the word metastasis, I think a lot of you have heard it and know what it means. It means that the disease is being transferred from the origin to a distant site. And despite the fact that it has been first described already in 1829, it's not totally understood how the mechanism works. Different type of cancer metastasize to the bone, but the most common ones are breast and prostate cancer. And that is also what we have heard this morning, where a high part of the morbidity of these diseases come from. The cancer cells get dislodged. The cancer cells who form metastasis have to have certain criteria. They have to be self-renewal, invasive, and motile, and they have to be able to survive when they are detached. So they travel via blood vessels to the distant site, and depending on the preferences of the tumor type, they settle down. And bone is quite a desired area to form metastasis because of the nutrient-rich environment. Bone is the third most frequent site of metastasis behind lung and liver, but it causes a huge problem in patients affected by this disease. They have skeletal-related events such as pathological fractures, severe pain, spinal cord compression, so it vastly influences their quality of life. So what's happening when bone metastases occur? There is a dysregulation in the normal bone remodeling process. In healthy bone, there is a balance between bone resorption due to the osteoclast and then followed by new bone formation from the osteoblast. The new bone the osteoblast lie down is called osteoid, and that is prior to it being calcified to regain its strength. And that can be distinguished in histology stains of non-decalcified bone sections, where the calcified bone stains black in this case, and the newly formed osteoid is blue. So it's not, like I mentioned before, not completely understood what the reasons for, and there are different types of bone metastases. There are some which are osteolytic. That means there's an excess amount of bone resorption, and some are osteoplastic, where there is an excess amount of bone deposition. It's not completely understood how the cancer cells manage to induce this, the different type of bone metastasis. It's thought that parathyroid hormone-related peptide plays a role, and if the cancer cell either have a high expression of this protein or they induce a high expression, it can lead to osteolytic lesions, or if this protein is not present and cleaved, which happens sometimes in prostate cancer, there will be a huge amount of bone deposition. Anyways, there is still a huge area of research to be explored. There are different treatment options for bone metastasis. Common is radiation, or also recently stereotactic body radiation, which is a more locally form of radiation where you can use much higher doses. Then chemotherapy, and then also bisphosphonates and small antibodies like denosumab. Bisphosphonates and denosumab influence the osteoclast activity and reduce it so that there is not an excess bone formation, bone resorption going on. However, there are also some side effects being reported, an increase in pathological fractures and also osteonecrosis of the jaw. And then other methods is radiofrequency ablation or surgery, where tumor-involved vertebrae, for example, get stabilized through the injection of bone cement. So a lot of these treatments focus mainly on the destroying of the tumor cells. However, because the bone is surrounding this tumor, it's very important to also know what happens to the bone. And we use a nude rat model to study this, and this one has a reduced, the RNU model has a reduced immune system, and that is also associated with hairlessness. And these rats are tolerate the injection of heterogeneous cancer cells very well. As I mentioned, we have 3 different type of lesions in the bone. We have osteolytic, osteoplastic, and a combined type. So we use 3 different type of cell lines to create this model. The first cell line we worked with have been identified as Hela cells, and Hela cells are the most known cancer cells and originating from the cervix, and they cause osteolytic lesions. So huge amount of, this is a tumor in the vertebrae of a rat, and then they create huge decrease in bone mass. When I started working with this cell line, we knew it under the name MT1 cells. And I researched the background of the cells, and I thought they came from a woman with breast cancer and breast cancer carcinoma, and that is how the cells were given to us from another researcher. However, when I finally sent them in for cell line testing, which is highly recommended to be done, they were identified and said they are Hela cells. This had been published before. However, when I did the search, this publication didn't come up because it was in a table, in a paper, and not in the keywords. However, and so a lot of the paper we published have still the old name on it, the other name of the cells on it. However, because we wanted to have a clinical model and not study any cell receptor specific diseases, we are still fine. The next cell line we start working with to create mixed metastases have been generated from a canine prostate carcinoma. And this cell line causes both type of metastasis. We see a huge osteolytic lesion, but also very close by we see new bone formation. So this is our model for the mixed metastasis. And now we were missing a third model, which was a pure osteoplastic cancer model. However, we were lucky. We did a literature search. We found a publication. I looked at the histology pictures. I liked what I saw. I ordered the cells. I injected them in the rats, and they grew 100% osteoplastic lesion in 100% of the injected animals. It's very rare that that happens, but one can be lucky. And the way the animals form the metastasis, is due to intracardiac injection. And it's very important. The cells are being injected into the left ventricle of the heart, which can be clarified due to the pulsating, very bright arterial blood. And then the cells, it's between 1.5 and 2 million cells in 200 microliter, will be slowly injected, and they circulate through the body, and they preferably settle in the bone. We follow the tumor development using bioluminescence imaging. And bioluminescence imaging is when the cells are transfected with an enzyme called luciferase, and then the animal get injected with luciferin, which is the substrate, and then the reaction takes place where photons are emanated from the tumor, the same principle what works in fireflies. And we use the xenogen system, which is able to detect the photons in a certain depth, and then we see in which area and overlays it with a picture of the rat, and we will see where the tumor are being formed or how they react to treatment. And because we are dealing with bone, we also can use CT imaging. For the first one with the osteoplastic lesion, we used a GE micro-CT imaging device with a voxel size of 150 microns. And for the ex vivo analysis of the bone, where we look at the bone metastasis and bone structure, we use a Scanco medical device which can go down to 7 microns, but most of the time we use a resolution between 13 and 20 microns. And I also looked where else some of the tumor cells lines produce metastasis. So for the Hela cells, we found the metastasis in the vertebrae and appendicular bones, the femur, tibia, scapula, and humerus. I also found it in the ovaries, brain, lung, spleen, and kidney and adrenal glands. So the same, I used to say the same places where breast cancer metastasized to, because originally I thought I was dealing with breast cancer cells, except we didn't find liver metastasis. And these are X-rays of the scapula. This is a normal scapula of a normal rat, and here we see osteolytic lesion, and here this is the scapula of a rat with the mixed metastasis, where you see osteolytic lesion, but then it's followed by a much denser, higher bone density. For the last model, we have micro-CT images acquired, and we saw approximately 4 to 5 weeks after tumor cell injection the first sign of the formation of metastasis. This is an axial view of the tibia, and then this is a caudocranial view, and you can see these little dots which then over time become more prominent. And then when we did the histology, we saw the huge increased bone formation in this area. There are very interesting patterns showing different stages of bone formation, but this needs further investigation of this relatively new model. And because we were mainly studying the effect of the disease and the treatment on the spine, we had to make sure that we have also lesion occurring in the vertebrae, and we analyzed the distribution along the different vertebrae in the rat, and this also helps us to determine if we want to do combined treatments, which vertebrae to choose, which have the highest likelihood to develop metastasis, and so on. The first treatment we explored, and to see what the effect is on the tumor, is photodynamic therapy. Photodynamic therapy is a combination of a photosensitizer, which is a drug, and light. So the photosensitizer is injected and then accumulates preferably in the tumor, and then after a certain amount of time, which is photosensitizer specific, laser light of a specific wavelength is applied to the tumor. This leads to a reaction where reactive oxygen species is formed, which does have a cytotoxic effect. So we treated, we placed a needle with a laser fiber beside the vertebra of a rat, and we treated it with PDT. And I did a long study where I tried to find the optimal light and drug dose. And then we came up with one drug and light dose, and we used that consequently for the other studies. We also checked on the effect using bioluminescence. So this is a huge tumor coming from the region between the thoracal and lumbar vertebrae. We did PDT treatment, and then you see there is no signal coming, indicating that the tumor cells have died, which was also confirmed by histology, where we could see an increase of necrotic tumor cells in the treated region and also a destruction of the cell membrane. The cell membrane of these tumor cells stains positive for EGF receptor antibodies, which also makes it much easier for us to analyze tumor burden, but you can clearly see that the stain decreased and that the tumor cells have been damaged. So we saw it's effective for the tumor cells. However, we also wanted to see what is the effect on bone, because you don't want to use treatments in patients where you kill the tumor cells but then cause a huge amount of damage to the surrounding tissue. So we were very surprised when we saw that PDT had a kind of a positive effect. We found an improved vertebral bone strength, stiffness, and architecture. And in the histology, we also saw an increase of bone formation on the ventral side of the vertebrae. And that observation led me to the idea to use this treatment in a different application. So for 2 slides, I will venture off from the cancer to fracture healing. So I used the PDT treatment on a critical sized femur defect, and we used the dose which has been identified working for causing the effect on the cancer-bearing rats. And then when I looked at the histology, I saw there was the same survival time in both rats. This is the histology of the femur of a control rat and this of a PDT rat. This black lines indicate the original fracture line, and everything in between the black lines is the new bone formation. And when I looked at the two, I saw here is much more woven bone visible. There is still cartilage present, which is a normal state of bone remodeling. And in the treated group, the bone looked much more organized, and it's much more difficult to distinguish from the original bone. However, this was an observation in histology. And when you do this type of observation, you always have to confirm this with a more objective method. And there is an increase in use of second harmonic generation analysis, which is an optical-based method looking at the organization of collagen fibers and fibrils. And this is different in different tissues. Most tissues obviously contain different type of collagen, but also the different diseases affect the structure of the collagen. So we used this method in for the fractured rats, and I found that there is a significant difference between and the ratio produced by this analysis indicates the amount of collagen organization. So the lower the number, the ratio, the more organized the collagen is. So the newly formed bone in the control group had a much higher number compared to the old bone, and that was significantly different. There was no significant difference in the 7-day PDT group, which means this fracture group received the PDT treatment 7 days after fracture generation. And that is an indication that the new structure is much more closer to the old structure. The observation I had in this group still needs some further investigation. And in a 15-week survival group, I didn't have significant differences between old and new bone, indicating that the newly formed bone had advanced in the remodeling process. And we used the same method to look at the different type of bone metastasis, and we found that, we found that there is a negative correlation between the measured susceptibility ratio and the hardness and modulus of the metastatic bone. So what I have shown you previously in the ACE1 model, where we see this new bone formation, which also looked like woven bone, this also has different collagen orientation and quality compared to the normal bone. So when we used the PDT with the same dose on the mixed osteolytic osteoplastic metastasis, we did not see a reduced tumor burden, but we still saw some changes on the bone structure. However, it was slightly different compared to the osteolytic model. So that also indicates that not all bone metastases are the same. We furthermore evaluated radiation treatment on bone metastasis. We wanted to see if you can treat a patient which has failed radiation effect with photodynamic therapy. So we tried to mimic that by only giving 4 gray to the spine to 3 vertebrae. However, we destroyed all the tumor cells present there, which can be seen in the bioluminescence imaging. And then we did not see a huge difference between radiation alone and the combination with radiation and PDT in the structure of the bone. This can be due to the fact that we only have a 7-day window to perform our observation, because this is a very aggressive cancer model. The rats, within 3 weeks, they show clinical signs and have to be euthanized. It will be interesting to see what happened in the osteoplastic model, where we can have the rats living for 3 to 4 months, because it's a very slowly growing model, and I only had seen some clinical symptoms in 1 rat after 4 months. And so we did combined treatment evaluation in healthy rats, and we were able to do a 6-week survival. And we saw more bone formation in the PDT treated group, but also in the combination with bisphosphonate and with radiation. This was also confirmed when we looked at the new bone formation. We saw much more osteoid formation. This time we used a different type of staining on the non-decalcified section, and we saw that there was an increase from new bone formation, and that was not seen with either treatment alone. As I mentioned, bisphosphonates are very often also used in patients with bone metastasis. So I first did an in vitro test, and I see if that the treatment with the bisphosphonate zoledronic acid has an influence in or affect somehow the PDT treatment. And I found that the PDT, the pre-treatment with bisphosphonate, makes the cells more susceptible to PDT. So they die off much faster than when they're treated with PDT alone, which I found very exciting, and I was hoping to repeat that in vivo. However, that did not happen. So we found that the bisphosphonate reduced the tumor burden overall in the vertebrae by 40%, but I did not see an enhanced effect in treating these animals with PDT. All these preclinical results led us to apply for funding for a phase 1 clinical trial, and this was performed in patients with single-level bone metastasis prior to receiving a vertebroplasty or kyphoplasty, which is the injection of bone cement in vertebrae, which is at high risk of fracture or already has fractured. And this was a safety study to see if how the patient tolerate this. And this clinical trial has finally just finished successfully. So the paper is being written up, and what would be the next step is under discussion. So what I showed you today is 3 different models to produce osteolytic, osteoplastic, and mixed metastasis, and that it's important to look at the bone architecture, and we also used histology to analyze treatment effects. And we also looked at bone material properties like collagen orientation and mineral content, and there's a couple more coming. And and I would like to thank the people I'm working with since I moved from Guelph to Toronto, and Dr. Vine. She is responsible for the whole biomechanical testing and structure analysis, and Dr. Wilson is an expert in photodynamic therapy, and Dr. Yi is the clinical spine fellow I'm working with, a spine surgeon who does all the clinical studies, and former and current people working with us. And the funding for the cancer studies was provided by the Breast Cancer Foundation, CIHR, and for the fracture study I got funding from DOD. I'd like to thank you very much for your attention, and I'm happy to answer questions. Paul?
Maybe a really basic question. Do animal models respond to radiation at baseline in a similar way to humans? Is DNA damage repair basically similarly avid, or is it different?
It is the same, but what I think we have to be careful with the dose. So what I learned from this, so we are just in the process of planning the next experiment with a much higher dose, and I'm very reluctant to fully listen to everything the radiation physicist says, because they base it on human bone, and what we have seen with the 4 grays, there are slight differences. So we have to do some more research. I have some students working on that to see where we start, and we have to do some preliminary studies, because if you give too much radiation, the poor animal is going to die.